Good morning. We're going to extend our discussion on applying the CLABSI surveillance definitions for NHSN to some case studies so that we can get some experience working with the definitions. So we're going to spend the next hour or so going over some case studies that we've put together. I do want to make a note, as I noted it on my earlier presentation, that this recording is being made on January 24th of 2013 after several modifications to the CLABSI surveillance definitions and protocols which occurred after the October 2012 NHSN training course. The slide set that was posted for this presentation is the original slide set, and it has some notations made to the slides that have been updated that'll allow individuals who attended the October training to identify those slides that have changed. And I provided you a link to that slide set here. So for today's recording, I have taken those note cards off because they're just kind of distracting and didn't really think we needed those. When this presentation was originally presented, it was given to a live audience, and we utilized an audience participation feature. And since today we don't have an audience, that feature has been disabled. Therefore, you'll see some empty spaces in some of the slides where we would have normally put the audience results. So just in case you're wondering why the slides might look a little lopsided, that's why. And what I envision doing now is that during the case presentations, I'll pause slightly to allow users or viewers to place the webinar on pause if you want after the question to consider the case. And then you can come up with a proposed answer, and then when you're ready to check your answer, just unpause the webinar and I'll be presenting the correct interpretation. Okay, so a few ground rules for case studies, which we always like to present this as the first information. And really the purposes for these case studies are to train on the use of the definitions as they exist. We talked a little bit about the difference between clinical and surveillance definitions in the previous presentation, and those will continue. You may see some cases in here where clinically you may disagree, but we are training on the use of the definitions and a surveillance for surveillance purposes and applying them consistently as they're supposed to be done. And we're hoping to optimize the inter-rater reliability by doing this and improving our data quality. So just remember that for today's discussion, the purpose is not to debate the correctness of the definitions, but to learn how to correctly use them. I covered this information earlier. For those of you that did not watch that earlier presentation, these are questions that you might want to ask yourself as you're working through the determination of whether or not something is a healthcare-associated infection. And specifically, you might first ask yourself, is it an HAI? If not, if it doesn't meet the criteria for an HAI, then you can stop your investigation. It's not for NHSN purposes, we wouldn't be reporting that. If it is an HAI, you might ask yourself which site-specific criteria is met, and then once you've determined that, then you might want to ask yourself if it's a device-associated HAI. If we're talking specifically about CLABSIs or LCBI, laboratory-confirmed bloodstream infections, you might also want to ask yourself whether it's a primary or a secondary BSI. And then finally, whether it's attributable to what locations or facilities it's attributable to. And in the case of an SSI, what procedure would it be attributable to? Now, if you're only doing CLABSI surveillance, you may determine to do this in a different order. You might first want to look to see if the patient had a central line in place. If there was no central line in place during the hospitalization, then the patient could not develop a CLABSI, central line associated BSI, and you could discontinue your investigation. Likewise, if you're only doing CLABSI surveillance in ICUs, if the patient had never been in ICU, then he could not have a CLABSI that's attributable to an ICU, and so you may want to stop your investigation there for NHSN purposes. So you may change the order of these based on your own facility's circumstances. So let's jump right into our case studies. The first case study is Ms. A, who is transferred to your facility with pancreatic cancer and a peripherally inserted central catheter, which is first accessed on day 1. On the 7th of April, blood culture was collected. That was collected on April 5th is growing Providencia stewarti, and no other organisms are isolated. The patient is started on antibiotics. I provided for you here some additional laboratory values. You can see that admission day is listed as as April 1st here, and we have WBCs for every day following that, and ANCs for 2 of the days. The blood culture was collected on April 5th, as I've shown you here, and it was reported on the 7th. So the first question is, does the patient meet criteria for an HAI? And the answer is yes, because all elements of the CDC NHSN site-specific infection criteria, in this case LCBI, were first present together on or after the 3rd hospital day. We're identifying the day of hospital admission as day 1. This is considered a healthcare-associated infection. It's also attributed to your hospital for the same reason, but we'll talk about that in a minute. So the next question is, what specific type of HAI does Ms. A have? An LCBI 1, LCBI 2, or an MBI LCBI 1 or 2? And the answer is that she has an MBI LCBI criterion 1. And let's see why. The patient meets the LCBI criterion 1 because she had a positive blood culture with a pathogen and no other recognized source. And additionally, the patient meets the neutropenic definition, which is 2 values of an ANC or a WBCs less than 500 on or within 3 calendar days before the positive blood culture collection. So as you can see, day of positive blood culture collection is here. We identify that as day 1. And on that day, she had an ANC of 400. And then on the day before, she had a WBC of 400. So you can see that it can be a mixture of ANCs and WBCs. It doesn't have to be just all WBCs or all ANCs. Additionally, the patient had an eligible pathogen. This was an Enterobacteriaceae, and no other pathogens were isolated from the blood besides an eligible organism from MBI LCBI 1. So the patient meets criteria MBI LCBI 1.2. Next question, is the CLABSI attributed to your facility or the transferring facility? I think I tipped you off to this earlier. The CLABSI is attributed to your facility because the device was accessed there. Remember that if a patient is admitted with a pre-existing central line, the line should be included in the central line day count and your CLABSI surveillance, starting with the first day that the line is accessed. And BSIs with a date of event on or after day 3 are attributed to the admitting facility. And remember, the date of event is the date that all of the element are first present together. Very good, so that's case 1. Let's go to our second case, Mr. B. Mr. B is a 73-year-old Caucasian male that's admitted to the ER on 6/10 with nausea and vomiting, abdominal pain, and fever. He has a past medical history of hypertension, hiatal hernia, esophageal reflux. His admission vital signs are noted here, nothing out of the extraordinary. His temp, however, is 38.0. And we do have some other things that you may want to note here. Amylase 4,900, lipase 4,000. WBCs are 22.7. And they did a CT of the abdomen, and it's suggestive of pancreatitis. He's admitted to the medical ICU on the 10th of June, with a diagnosis of pancreatitis. On the 10th, he continues to run a fever, and it actually jumps to 102 Fahrenheit. He has an NG tube that's placed. He's made NPO. He has IV fluids and supportive care begun, and they draw 2 blood cultures. On the 13th, because of his poor peripheral access, they start a central line, left subclavian, and they begin him on TPN after verifying the by chest x-ray the placement of that central line. The blood culture results from the 10th are negative. He's transferred to 6 North Surgical. He's afebrile on the 13th. On the 15th, he's still afebrile. His chest x-ray shows some fluid, indicative of congestive heart failure. He has some Lasix administered to correct. On the 16th, he's afebrile. He has an increased abdominal pain and vomiting, and they start some Levaquin and Flagyl. Now we're going to jump ahead to the 27th when he is afebrile. His TPNs has been discontinued because he's tolerating his PO intake. And 3 days later, he's still afebrile. They discontinue his central line, and they transfer him to 5 West Medical after discontinuing his Levaquin and his Flagyl. On the 1st of July, his fever is 100.8, so his temp has gone up. He has some nausea and vomiting, and he has blood cultures ×2 collected. The next day, his fever is not present, but one of the blood cultures in one set was positive for staph epidermidis, and one bottle in the other blood culture set is positive for coag-negative staph, and they begin vancomycin. By the 4th, he's afebrile, and he's actually discharged on the 11th. So, question number 1, is there an infection? If there is an infection, is it POA or HAI? And the answer is it's HAI. It occurred, all elements first occurred on or after hospital day 3. First occurred together on or after hospital day 3. What site-specific criteria would you consider when you're making this determination? Well, you're probably going to look at LCBI or laboratory confirmed bloodstream infection because you have a positive blood culture. So that's the first place you're going to start. And then we're going to ask ourselves, is it a device-associated infection? Well, let's consider this. The patient had his central line inserted on the 13th of June, and it was discontinued on the 30th of June. On July 1st, he had a fever, and he had blood cultures that were collected, and they were positive for staph epidermidis and coag-negative staph. So, was a central line in place for greater than 2 days on the day of the BSI? The answer is yes. And was the central line in place at the time of the blood culture, or if it had been discontinued, which is the case here, was criteria for LCBI met on the day of discontinuation or the next day? And the answer to that is yes, it was on the next day, the 1st. So this is considered a device-associated BSI. Just to show you, this is a LCBI criterion 2. Patient had fever and the positive laboratory results that were not related to an infection at another site, so it's primary. And patient had 2 or more blood cultures drawn on separate occasions that showed a matching common commensal, in this case, staph epidermidis that was described as coag-negative staph in the second culture. So, if there is or was a CLABSI, to which unit should be attributed? Choices are medical ICU, 5 West Medical, or 6 North. And the correct answer is 6 North. Let's see why. Remember that if all elements of an HAI are present within 2 calendar days of transfer from one inpatient location to another in the same facility, in other words, on the day of transfer, the next day, the HAI is attributed to the transferring location. If we go back, patient was transferred to 5 West on 6/30. The date of infection is the next day, so it's not the date of transfer, but the next day. Therefore, it is attributed back to 6 North, the transferring location. Very good. Ms. C. Ms. C is a 45-year-old female with newly diagnosed stage 2B endometrial cancer that's admitted to the Women's Center on 11/2 for a total abdominal hysterectomy, as well as bilateral salping ovarectomy and removal of pelvic and abdominal lymph nodes. She's also scheduled to have a PICC placed for participation in a clinical trial. She has a 3-month history of new onset of pelvic pain and dysmenorrhea. She's had 2 previous C-sections, and the last one was 10 years ago. Her admission and vital signs are unremarkable. They placed the PICC line in interventional radiology on the 2nd. She's typed and cross-matched for 2 units of packed red blood cells for anemia, and she receives that transfusion through her PICC on that same day. She has her surgery on the 3rd. There's no complications. She's transported back to the Women's Center from a post-op recovery unit. The next day, on the 4th, she's still afebrile. Her post-op antibiotics are discontinued. The dressing is changed, and the incision has no signs of erythema or drainage, and the Foley is draining clear yellow urine. On the 5th, the patient is ambulating with assistance. They take out her Foley catheter. Her dressing remains dry and intact. She has her first bowel movement without any difficulty, and she's medicated for abdominal pain. She's having a pain of about an 8 on a 1 to 10 scale. On the 6th, she's running a fever. Her fever is 38.8 degrees Celsius maximum. She continues to complain of abdominal pain that's unresolved with pain meds, and she has a slight tenderness noted on palpation of her left lower abdominal area. On the 7th, her temp is 39 degrees. Her blood cultures are collected ×2. She's sent for a CT, which shows an abscess present in the left lower abdominal cavity. They drain that and culture the purulent material that's sent. IV is placed and antibiotics are started. On the 9th, she is afebrile. Her blood culture is positive for VRE and Bacteroides fragilis ×2, and the culture from the abscess is positive for B. fragilis also. The patient reports a decreased abdominal pain. And on the 12th, the patient's drain is removed. Her abdominal signs are present. She has a follow-up CT scan that shows that the abscess is resolved, and she is discharged. So the first question is, does the patient have an HAI? And you can choose that yes, she does, no, she does not, or C, you are not sure. And the answer is that yes, the patient does have an HAI. Remember that all elements of a CDC NHSN site-specific infection criteria were first present together on or after the 3rd hospital day. In this case, she has met criteria for a SSI, a surgical site infection. If so, what type? Hopefully I just didn't give away too much. Your traces are the patient only has an intra-abdominal infection, IAB with B. fragilis. 2, the patient has an organ space SSI IAB with B. fragilis and a CLABSI with VRE and B. fragilis. C, the patient has an organ space SSI IAB with B. fragilis and a VRE. In this case, the BSI is secondary to the IAB. Or finally, the patient has an organ space SSI IAB and a secondary BSI with B. fragilis and a CLABSI with VRE. The answer is C. The patient has an organ space, SSI, IAB with B. fragilis and VRE, and the BSI is considered secondary. So we have to go back to Appendix 1 in this situation for guidance. Appendix 1 is found in Chapter 4 of the CLABSI event chapter in the NHSN Patient Safety Component Manual. The appendix is at the end. Excuse me. The appendix is a secondary BSI guide. And what it states is that in a patient suspected of having an infection where blood and a site-specific specimen are collected for culture and both are positive for at least one matching organism, and that's what we have here. We have both cultures have B. fragilis, although the blood culture also has VRE in it. If the site-specific culture is an element used to meet the infection site criterion, then the BSI is considered secondary to that site-specific infection. So specifically in this case, it's saying that if the culture from the purulent fluid is used to meet the IAB criteria, then we're going to identify the BSI as secondary. And in this case, that's exactly the case. The patient meets IAB criterion 1, which is organisms cultured from purulent material from the intra-abdominal space by invasive procedure. A site culture is used to meet this definition. So this patient has an SSI with secondary BSI with both organisms, even though the VRE was not recovered from the IAB. But it is a logical organism that we might expect to see in an intra-abdominal abscess. As you can see here, the patient meets the organ space criteria within 30 days after the procedure, and because there was no implant, and actually this is I'm just realizing this is an old shot from the manual. I need to update that. But the patient, because we no longer have the 30 days with implant rule, the infection involves any part of the body, excluding the skin, fascia, or muscle layers. It's opened or manipulated during the operative procedure, and the patient has organisms isolated from an aseptically obtained culture of fluid or tissue in the organ space. And additionally, the patient also meets C, an abscess or other evidence of infection involving the organ space found on direct exam during re-op by histo or radiologic exam. In addition to meeting the organ space infection, as you know, the patient also needs to meet one of the site-specific organ space infections. In this case, it's the IAB, intra-abdominal infection. And the patient has organisms cultured from purulent material from intra-abdominal space obtained during the invasive procedure. So that's number 1, and that's the one that's determining that this BSI is secondary. But you can see the patient also meets criterion 3, fever, abdominal pain, organisms cultured from a blood, and a positive CT scan. Very good. So we'll move along to Mr. D. Mr. D is a 79-year-old male admitted with gastric cancer, has a central line placed on the day of admission for total parenteral nutrition. On the 16th, he has a partial gastrectomy that's performed. Patient's progressing well until he spikes a fever of 101.3 on the 21st, and they send some blood cultures. On the 22nd, he continues to have increasing abdominal pain. They do a CT scan of the abdomen. It shows a small fluid collection that's posterior to the stomach. Fluid collection is fully drained by ultrasound-guided needle aspiration, and purulent fluid is sent for culture, and the blood cultures are repeated. On the 23rd, the blood cultures from May 21st are one of 2 positive for staph epidermidis. Abdominal fluid is growing gram-positive cocci, and they start antibiotics. And on the 24th, the abdominal culture is positive for E. cloacae. The blood cultures from the 22nd, 2 of 2 are positive for coag-negative staph. So, first question is there an infection? If there is an infection, is it an HAI? And the answer to this is yes, and probably by now you guys are getting very good at identifying that. If all elements of the infection criteria were first present together on or after the 3rd hospital day, with day of hospital admission being day 1, then the infection is considered healthcare associated. Second question is, does this patient have a CLABSI? Your choices are yes, the patient has a CLABSI with staph epidermidis. No, the BSI is secondary to the abdominal infection, or you can say, geez, I'm just not sure. And the answer is that no, this BSI is secondary to the abdominal infection, and let's look at why. Again, we have to go back to Appendix 1. And when a patient suspected of having an infection has blood in a site-specific specimen cultured, but the organisms do not match, such as we have here, if the site-specific culture, in this case the abdominal fluid, is an element used to meet the infection site criteria, and in this case it is IAB criteria 1, and the blood isolate is also an element used to meet another criterion at the same infection site, and in this case it is IAB criteria 3C, as we mentioned earlier, involves a blood culture and a positive CT scan with symptoms. Then in that case, the blood BSI is considered secondary to that site-specific infection. So this is an SSI IAB with both E-cloacae and coag-negative staph. Now this might be one where you have, your clinical decision may make you a little uncomfortable because coag-negative staph might not be the first organism that you think of when you think of an intra-abdominal infection, but this is, we're going to stick with the consistency of the definition and identify it as such. Okay, Ms. E. Ms. E is a 41-year-old female that presents to the emergency room in diabetic coma and with anemia. She has a subclavian catheter inserted in the emergency room, and the next day in the ICU she has a midline catheter inserted and she received some blood transfusions. This is all on August 14th. On the 17th she develops fever of 39 degrees Celsius and shaking chills, and they send 2 sets of blood cultures. On the 19th those blood cultures are positive for Pseudomonas aeruginosa, and neither insertion site shows inflammation, and there's no other documented infection. So the question is there an LCBI? Choices are no, yes, it's an LCBI with Pseudomonas aeruginosa, or C, you're not sure. The correct answer is yes, the patient has an LCBI with Pseudomonas aeruginosa. So let's ask you, which criterion of LCBI does this patient meet? Criterion 1, recognized pathogen, or criterion 2, 2 or more positive blood cultures with a common commensal and fever and chills. And the correct answer is number 1, criterion 1, because the patient had Pseudomonas aeruginosa. What unit should be indicated for the location of the device insertion field? When you enter this BSI into NHSN, there is a field that asks for the location of device insertion. Would you record it as the ED? Would you record it as the ICU? Would you record it as neither of those two, something else? Or you're not sure? Correct answer is that ED should be indicated as the location of device insertion. But I do want you to remember that although the line was inserted in the ED, the LCBI will actually be attributed to the ICU, and that's according to the transfer rule and the exception to the transfer rule, specifically the fact that the ED cannot have CLABSIs attributed to it because it's not a bedded location. There's no overnight stays, and there's no summary data such as central lines or central line days or patient days that are collected in that area. So it has to be attributed to the next location. This is a CLABSI because the line was inserted on 8/15, and all elements of the BSI criteria were first present together on 8/17 when the central line had been in place for greater than 2 days. Now, I just want to highlight that the location of insertion field is an optional field. You do not have to fill that in, but if it's something that you do want to collect in this situation, ED would be the correct location. Okay, let's change the scenario and say that on the 17th, the patient's subclavian catheter site is red and has a small amount of pus. Does this change your decision? You can say, nope, they still have a CLABSI, or yes, it's no longer a CLABSI. The correct answer is that this is still a CLABSI. I want to bring your attention to the criteria for cardiovascular system infection, which is found in Chapter 17 of the NHSN manual. This patient meets criteria 4, which says the patient has purulent drainage at the involved vascular site and the blood culture is not done or no organisms cultured from the blood. Actually, I highlight that because they don't meet that. They don't meet any of the criteria. They specifically don't meet this part of the criteria because there was a blood culture done. So if you look at the reporting instructions, they're at the bottom of this definition, you'll see that the second bullet says, report intravascular infections with organisms cultured from the blood as BSI LCBI. So because the patient's got this infection that's involving this intravascular catheter, and there's positive blood culture, we're going to report it as a BSI. I do want to bring this to your attention because sometimes people, the first thing they think of when they have a patient that has an infection, what appears to be an infection at a catheter site, is that they're trying to determine whether it's a BSI that's secondary to a skin infection. And really, when it's involving a catheter, you need to look at the vascular, the CVS, VASC criteria, not the skin infection. Moving along, Ms. F. Ms. F, who's 10 years old, has been in PICU for a week with a central line in place the entire time. 4 months ago, she received an allopoietic stem cell transplant for AML, acute myelocytic leukemia. She currently weighs 25 kilograms. On the 6th of April, the line is pulled. And on April 7th, she becomes disoriented and hypotensive. Her blood cultures are collected ×2, and they send urine cultures as well. One of the blood cultures is positive for strep mutans, and the other is reported as positive for Viridans group strep. So the first question is this a BSI, and if so, which criterion? Yes, this patient has an LCBI criterion 2. She has hypotension and 2 or more blood cultures with a common commensal that's considered to be the same organism and not related to an infection at another site. So strep mutans is included in the Viridans group strep, so those are matching blood cultures. Is it a central line associated BSI? And the answer is yes. This is a central line associated BSI. Remember that the device was in place for more than 2 calendar days when all elements of the CDC NHSN site-specific infection criterion were first present together. What organism should be reported? You're going to report S. mutans. And just to remind you that when you have 2 organisms that are matching, 2 common commensals that are matching 2 organisms, and one is reported at a more detailed level or a more specific level, you're going to report the more specific. In this case, strep mutans is more specific than Viridans group strep, so that's why it's reported that way. Okay, so what happens if there was gastrointestinal graft versus host disease documented from Ms. F? Would that change your determination? Well, this is actually still an LCBI criterion 2. The description of GI, GVHD has to be very specific. It has to say that it's either a grade 3 or a grade 4 to meet criteria for an MBI LCBI criterion 2 1A. Just GI VHD is not enough. What if on April 4th she had 625 milliliters of diarrhea? Does that change your determination? Well, let's take a look here. We've put the information that onto this table. So table 1, April 6th is identified as day 1 because that's the day that the first blood culture is collected. We also had one on April 7th. And then we had diarrhea, we said 625 milliliters on April 4th. So does that make a difference in our determination? And the answer is yes. So we know that the patient meets LCBI criterion 2 already. She has a common commensal identified in her blood. It has a match within 2 days, and she has no other site, and she's also had symptoms. Additionally, the patient also meets allogeneic hematopoietic stem cell transplant definition, specifically that she has had more than 20 milliliters per kilogram of diarrhea in the 24 hours, within 24 hours, on or within 7 days prior to the blood culture. So let's look at the timing. This is the day of the blood culture. Within 7 days, 1, 2, 3, 4, she's -4. That's well within the 7 days. And if we did the math, we would see that according to the requirements, at 25 kilograms, she would only require 500 milliliters of diarrhea at a minimum, and she had 625. Additionally, she had, the blood culture was only growing Viridans group strep and no other organisms. So therefore, she does meet now MBI LCBI criterion 2, 1B. Now, I'm giving you these criteria and listed as 2, 1B. When you report it into the NHSN system, you'll just identify it as an MBI, LCBI, and you will be putting in the elements, the criteria that you met. But I'm giving you this further information so that you can go back if you want to and look at the specific criteria that are met. So this just shows you the criteria and where she actually met these. Won't spend too much time on that. What happens if the second blood culture, in addition to the Viridans group strep, also grew micrococcus? So one of the blood cultures grew micrococcus additionally. This is still an MBI LCBI because that single culture of micrococcus without a matching blood culture within 2 days does not meet the LCBI criteria. So it's considered a contaminant, and we would not exclude the MBI LCBI for that reason. What happens if it was Staph aureus? So they had, instead of having just Viridans group strep, they also had that and Staph aureus in their blood. In that case, it couldn't meet MBI LCBI criteria because remember, it can only, criteria 2 can only contain Viridans group strep, and criterion 1 for MBI LCBI 1 can only include a certain set of organisms, which are gut organisms, Staph aureus, which is not one of those. So this would then be classified as an LCBI criterion 1, a pathogen, and in a positive blood culture, and no other recognized cause. Okay, very good. Moving along, Baby Z. Baby Z is a 1-day-old twin male infant admitted and emergently transferred to the neonatal intensive care unit. Intubated during transport and admitted with a peripheral IV in the scalp that's infusing at 1 cc per hour with Prostin started prior to the transport. And patient also has an umbilical venous catheter. Gestational age was term. Birth weight was 1,810 grams. The APGARs were 5 and 6. An echocardiogram showed transposition of the great vessels of the heart. On day 3, they repaired the patent ductus arteriosus and the atrial septal defects. And later that day, the umbilical catheter site was noted to be slightly red. On day 4, the umbilical site continues to be red, and a low-grade temperature has developed. And on the 5th day, there is one blood culture that's drawn through the umbilical line. The line was discontinued, and the catheter tip was sent for culture. They then placed a PICC line. On day 6, the patient continued to have elevated temps. It was reached as high as 38.1 degrees Celsius rectal, and they started antibiotics. And on the 7th day, the blood cultures were negative, but the umbilical catheter tip was positive for staph epidermidis, more than 15 colonies, and they adjusted the antibiotics. So the first question is, if this patient has an infection, is it an HAI? It is an HAI. All elements of the CDC NHSN site-specific infection criterion were first present together on or after the 3rd hospital day. And which criteria would you consider? LCBI, 2 or 3. Babies less than a year of age, so either one would be reasonable, and this is a common commensal organism, so those would be the logical criteria that you would consider. Would you consider it to be device associated? And the answer is yes. The device was in place for more than 2 calendar days when all of the elements of the infection criterion were first present together. Does the patient have an LCBI? Patient does not have an LCBI. So we considered those criteria, but the patient actually did not reach them. And that's because the catheter tip cultures are not utilized for NHSN LCBI criteria, only blood cultures, and your blood cultures were negative. The patient actually meets criterion 5 of vascular, if you look at that criteria, has a fever and greater than 15 colonies are cultured from the intravascular cannula tip using a semi-quantitative culture method, and the blood culture was not done, or in this case, there was no organisms cultured from the blood. So if you're reporting or following vascular infections, this is one that you would report. This is just a screenshot to show you the criteria, and opposite of what we had earlier where we had positive blood organisms from the blood. In this case, we actually don't have any, and so we're going to report this as CVS VASC. So let's change this just a bit. What if the catheter tip had been negative, but the blood culture was positive for staph epidermidis? So instead of a catheter tip, we have a positive staph epidermidis in the blood, 1. Would the baby have an LCBI? The answer is no, because we only have 1 culture from the blood that's positive with common commensal. We need a supportive, matching common commensal collected within 2 days from the blood, and we didn't have that, so we can't call this as an LCBI. So let me ask you a denominator question. If the patient had both the PICC and the umbilical line at the same time, how would her device days be counted each day? Would you count her as having 1 central line day, 2 central line days, 1 umbilical line day, 1 central line day, and 1 umbilical line day? Or you could say you're not sure. The correct answer is that you would count that as 1 central line day. Remember that umbilical catheters are no longer counted separately in NICUs from other central lines, and therefore we only count this as 1 central line day. Ms. G. Ms. G is a 7-year-old that's admitted to the ICU from the ER on June 1st with a 5-day history of fever, vomiting, and diarrhea, which became bloody 2 days ago. The patient's oral intake has been very small, her pulse is weak and thready, and she is hypotensive. On the 1st, a Foley catheter is inserted as well as a right subclavian central line in the ER. They collect urine, stool, and blood cultures, and they start some IV hydration with her. On the 2nd, she has occult blood in her urine, and her output is decreased. The lab reports that her stool is growing suspected E. coli 0157H7. On the 3rd, she's experiencing very low urine output, and it's grossly bloody. She had moderate bruising. Her labs are indicative of anemia. She has an increased reticulocyte count. Her left upper extremity PICC line is placed. They start hemodialysis, and that hemodialysis is administered by contract staff via this dedicated PICC line. Fluids continue, and she is started on corticosteroid therapy. On the 4th, E. coli 0157H7 infection is confirmed, and the organism is present in the blood and stool. So this is a BSI that's present on admission. Met the criteria within the first 2 days of hospitalization. On the 6th, patient's on hemodialysis and they're continuing supportive therapy. Her labs are stable except for a slight increase in her WBCs to 11.7. On the 10th, she experiences blood pressure fluctuations. Pressors are instituted. Her WBCs are elevated since yesterday at 15,000. They collect blood and urine for culture, do a UA, which is negative for both leukocyte esterase and nitrate, and has 2 WBCs per high power field of spun urine. On the 11th, the blood cultures are positive, 2 of 2 for MSSA, and her urine culture is no growth. Does Ms. G have an HAI now? And you can say yes, she has a CLABSI with MSSA, meets LCBI criterion 1. No, the patient had positive blood cultures on admission, so this is not an HAI. Or no, the patient had an infection at another site, so it's not a BSI. And the correct answer is yes, that this patient has a CLABSI with MSSA, criterion 1A. Patient had a clear new onset of infection with blood pressure lability and positive blood culture. There was no other identified related infection at another site, and the central line had been in place for more than 2 days at the time of the blood culture. Is it attributed to your facility? Now remember that you had contracted staff that was providing this hemodialysis to this patient via this dedicated line. So you can say, yeah, you still have to call it as attributed to your facility, or no, it's attributed to the dialysis company. The correct answer is yes, it is attributed to your facility because facilities are responsible for the care that's provided by contracted staff within our facility. If there is a quality issue that's related to contracted staff, then that needs to be addressed and actions taken to prevent infections that could occur as a result. What if she had been transported from her patient room to an inpatient dialysis unit within your hospital each day for dialysis? Probably a lot of you have this situation. You have a dialysis unit where inpatients go, get dialyzed, and then come back to your one of your units for overnight stay and for the rest of their care. So if that was taking place instead of the contracted staff, would that make a difference? Again, would you attribute that infection to the ICU, or would you now attribute it to the dialysis unit? And in this case, the CLABSI has to be attributed to the ICU because the dialysis unit is not a bedded location. Again, there's no central line days that are collected on that unit, nor patient days, and so it has to be attributed to the ICU. Now, if you identify that you have a lot of infections that seem to be related to patients that are going, a lot of BSIs that are attributed to a lot of patients that are going to the dialysis unit, this may be something that you want to look into, so I would keep track of that in the comments section, which can be analyzed within NHSN. You can also create a custom event in NHSN to track such events, and you might call it potential dialysis-related events or something along that line. And then that's another way for you to keep track and to do some sort of quality improvement. Okay, Mr. H. Mr. H is a 66-year-old male that's admitted to the SICU following a robotic-assisted Lima harvest and coronary bypass graft with both a chest and leg incision. During surgery, the patient suffered a right ventricular injury, which required a pump-assisted approach for repair. A left groin incision was made for that purpose. The code for that, the ICD-9 code for that repair is 39.61, and for your purposes and your knowledge, this is not an operative procedure within NHSN. A central line was placed in the right subclavian vein. 2 days later, the patient was progressing well and was transferred to the intermediate care with a central line. On the 5th, the left groin incision with purulent drainage has purulent drainage, redness, and tenderness, and a temp of 100.8 maximum is noted. An aseptically obtained groin wound drainage is sent for culture as well as blood cultures, and they begin vancomycin. The groin wound and the blood are positive for gram-positive cocci, and on the 7th, both cultures are identified as methicillin-sensitive Staph aureus. The wound culture was pure. The antibiotics were changed to match the sensitivities with second-generation cephalosporin. So which of the following is true? A, this patient had a superficial SSI and a CLABSI with MSSA. Both should be reported to NHSN. B, the patient has a CLABSI with MSSA that should be reported to NHSN. Or C, the patient has a skin infection with MSSA with a secondary BSI. The BSI would not be reported to NHSN. Correct answer is C. Here's the rationale. The infection onset was greater than 2 days after admission. It was actually 4, so that makes it an HAI. The central line had been in place for greater than 2 days at the time that all elements of the infection were first present together. That makes this a device-associated infection. But the patient meets criteria for infection at another site, and the organisms from the blood and the site match. And we'll see the next slide. Just to note that because the ICD-9 code is a non-operative code, there could be no SSI related to this infection. So the patient meets the skin infection, purulent drainage, pustules, and vesicles. Also meets criterion 2, tenderness and redness, organisms cultured from the aspirate of the affected site, and also the patient had positive blood cultures. What if the wound drainage was positive for MSSA, but the blood cultures were positive for Staph epidermidis, 2 of 2? Would the patient have an HAI, and if so, what type? So now we're dealing with a situation where we have a site-specific culture that has one organism and the blood culture that has another organism. There's no matching organisms involved. Your choices are the patient has a superficial SSI with MSSA and a CLABSI with Staph epi, or the patient has a skin with secondary BSI with both MSSA and Staph epi, or the patient has a skin with MSSA and a CLABSI with Staph epi. Correct answer is that the patient has a skin with secondary BSI with both MSSA and Staph epi. And again, pulling from Appendix 1, when a patient is suspected of having an infection, has blood and site-specific infection culture, but the organisms do not match, if the site-specific culture is an element used to meet the infection site criterion, in this case it's skin, criterion 1, and the blood isolate is also an element used to meet another criterion at the same infection site, and in this case skin criterion 2A, then the BSI is considered secondary to that site-specific infection. Mr. I. Mr. I is a 55-year-old male that's brought to the ED on 6/17 with multiple injuries from a motor vehicle accident. He has IV catheters in his right forearm and left forearm by EMS. He's got a normal saline drip and through each line, and they inserted a Foley calf. He has a history of a left inguinal hernia repair that was done 2 years ago, and he is an insulin-dependent diabetic. You can see from his vital signs and labs are provided here for you. Microscopic urinalysis showed 40 to 50 red blood cells and few WBCs. Protein was slightly positive. He went to the OR on the 17th and had an open reduction internal fixation of a left femur, splenectomy, repair of a small bowel. Took 5 hours, 35 minutes, primarily closed, had general anesthesia, and an ASA class of 4E, contaminated wound class. On the 17th, all dressings were clean, dry, and tracked. Foley was draining. The NG tube was in place. The patient was on a pain pump. On the 18th, the temp is 99.6. Central line is inserted. The dressings are clean, dry, and intact. Foley is without issues. On the 19th, the temp is 99. They started TPN. The dressings were changed, and the wounds look okay. Then the Foley is draining clear yellow urine. Patient's improving from 620 to 625, and the maximum temperature during that time was 99.2. But on the 26th, the temp is 101.2. Patient still on TPN. They pan culture the patient. The urine analysis shows 20 to 30 WBCs per high power field. 2 sets of blood cultures are drawn, one from the central line and the other from the right arm. And they start antibiotics and pull the central line. The next day, temp is 100. Urine culture is positive for gram-negative rods greater than 100,000. No culture from the blood culture so far. The next day, the organism in the urine is identified as Pseudomonas aeruginosa. The blood culture from the central line is positive now for E. coli, and the set from the right arm as well. And on the 1st, they discontinue the Foley and transfer the patient to inpatient rehab. Does this patient have an HAI? The answer is yes, the patient has an HAI because all elements of the infection criterion were first present together on or after the 3rd hospital day. Which type of SSI? Correct answer is this patient has a SUDI, symptomatic UTI with Pseudomonas aeruginosa and a CLABSI with E. coli. Again, we have to go to Appendix 1 in a patient suspected of having an infection where blood and site-specific specimen are collected, but the organisms do not match. If the site-specific culture is an element used to meet the infection site criterion and the blood isolate is not, then the BSI is considered a primary infection. We do not have a SUDI criterion utilizing a blood culture as one of the elements unless it's in a booty, and this patient did not meet a booty criterion because he was not asymptomatic. Here's your criteria. Remember that fever is a non-specific symptom of infection, and if a fever is present, you can't pick and choose which criteria to attribute it to, even if you think that clinically you have a good idea of what's causing the fever. It has to be applied to all criteria that are eligible. I think we have 2 more. Baby X is a 2-week-old, 26-week gestational age infant that's transferred from another hospital to your level 2-3 nursery with a right lower extremity pick in place on the 3rd of October. The baby was weaned from the ventilator 2 days prior to transfer and now remains on 2 liters of oxygen by hood. On the 5th, which is specifically at 36 hours after transfer, the baby is irritable and his respiration rate has slowly increased from admission rate of 46 to the current rate of 80. It's got nasal flaring and chest retractions. It's got high heart rate at 175 beats per minute. They note rales in the right lung and DSATs to 88%. Oxygen is increased to 4 liters. A chest x-ray reveals pneumatoceles, probable pneumatoceles in the lower right lung, and 1 set of the blood cultures are collected through the PICC line and empiric antibiotics are begun. On the 6th, another chest x-ray still shows probable pneumatoceles in the right lower lobe. WBCs are 3,500. And on the 7th, blood cultures reveal Acinetobacter baumannii. Which of the following is true? This is not a primary BSI. It's a secondary to an infection at another site, specifically pneumonia. So no BSI would be reported by itself. This is a primary BSI, CLABSI, and should be reported. Or this is a secondary BSI and should be reported to NHSN as a CLABSI. The answer is that this is not a primary BSI. It's an infection, it's a secondary to an infection at another site, pneumonia, and you would not report any separate BSI. Specifically, you can see here that the baby met criteria for pneumonia 2 with pneumatoceles, I think it was leukocytosis in this case, rails, and worsening gas exchange, and positive blood culture. Should the HAI be attributed to your hospital or to the retransferring facility? HAI should be attributed to your hospital. Remember that what the transfer rule states, and in this case, the baby was transferred on the 3rd, and on the first day that all of the criteria were present together is not until day 6. And as a result, the HAI, the pneumonia is considered as it was on day 3 or more, and so this is considered attributable to your facility and not the others. I was thinking here that this is a BSI and it would be here, but we're not talking about a BSI, we're talking about a pneumonia, and all of those criteria were not present until the 6th of October. Ms. Y is a 50-year-old patient that's been on your unit for 7 days receiving induction chemotherapy for diffuse large B-cell lymphoma and has had a central line throughout. Because of tachycardia, she's had 2 blood cultures drawn. She's got no other signs or symptoms. 2 days later, on the 7th, she's growing Bacillus cereus from 1 blood culture and Bacteroides fragilis also, and the second blood culture is positive for Bacteroides fragilis and E. coli. Because we're thinking because this patient is a chemotherapy patient, perhaps they meet criteria for an MBI, LCBI criteria. So I plotted out the ANCs and WBCs for you here to use, and I identified that the day 1, which is the positive blood culture collection date, which was April 5th, is here in the box. And you can see that this patient had several days where the ANC was less than 500, and a couple where the WBCs were also less than 500. So which of the following is true? No LCBI criteria are met. Patient has an LCBI 1 with Bacillus cereus, Bacteroides fragilis, and E. coli. Patient has an MBI LCBI 1 with B. fragilis and E. coli only. Or patient has an MBI LCBI 2 with only Bacillus cereus reported. Number 3 is correct. Remember that this patient meets criterion 1, had a pathogen recovered from blood culture with no other recognized source, was neutropenic within at least 2 days of ANC or total WBCs less than 500. We identified that within 3 calendar days before or on the day of blood culture, and we've identified that. The organisms were all eligible pathogens, Bacteroides and E. coli, and there were no other organisms recovered. The single culture of Bacillus does not exclude because it doesn't meet criteria for an LCBI. So this patient meets criteria for MBI LCBI 1. And that is the extent of our case studies today. I hope that they've been helpful to you. I know that you may want to review them in depth, and hopefully you'll be able to do that utilizing the pause feature here. Thank you very much.